Hey, what's going on, guys? Today we're going to be going over Chapter 5, the Mental Status Assessment and Health Assessment textbook. I've roughly kind of skimmed over this, so I know what I'm kind of talking about. So let's begin. It's defined like mental health. So it's basically like emotional and cognitive function. Basically, you can figure out like the potential individual can cope, can be productive, and contribute to community, basically. Let's talk about mental disorders. So, say you have a traumatic life event, you'd expect like a certain reaction, but a mental disorder would be like you have a reaction, but it's like tenfold, so it's like a lot greater. So it's like usually not that. So a good example would be like depression, having feelings of that are unrelenting or include delusional or suicidal thinking, low self-esteem or worthlessness, loss of ability to function. There are two types of mental disorders, like organic and psychiatric mental disorders. Organic are of known cause, so like delirium, dementia, alcohol and drug intoxication, and withdrawal. And psychiatric mental, we don't know what causes them, like anxiety and schizophrenia. When we assess mental status, we assess its functions that are inferred through assessments of like individual's behavior, like consciousness, being aware of his surroundings, language, how they use their voice, mood and affect. Affect is like a temporary expression of their feelings, and mood is their long-term feelings of how they feel. Orientation, it's like orientation of person, place, and time. Attention is like concentrating, focusing. Memory, being able to remember stuff. Recent memory, focus on day-to-day memory. Remote memory, focus on years worth of experiences. Abstract reasoning, thinking beyond the just general meaning. Thought processing, how someone thinks. Thought content, what they're thinking about. And perception, awareness of objects through five senses. Going on to developmental competence, talk about infants and children. We can actually trace language development in children. Starting at 4 weeks, they start to cry. Going on to 6 weeks, they start to coo. 1 year, they're forming one-word sentences. And 2 years, they're doing multi-word sentences. There are certain disorders for a child. It's called childhood mental disorder. It's diagnosed and begins in childhood, such as ADHD, anxiety, depression, autism, things like that. Going on to the aging adult, it's not really any problems with mental-wise. You might think there would be because it takes longer to respond, but that's just because they're getting older. Some things that do affect it are like consonants. They're having a hard time hearing consonants, and the recent memory is a little bit declining in that too. Something that I want you to know is components of the mental status exam are made up of appearance, behavior, cognition, and thought processes known as A, B, C, and T. Those are very important. I think you should know. Let's get on to this objective data. So first, going to look at appearance. The A, going to look at their posture. Should be erect and relaxed. Body movements, they should be voluntary, deliberate, coordinated, smooth, and even. The dress should be appropriate for setting, season, age, gender, and social group. Grooming and hygiene kind of makes sense, and pupil size could make sense. Looking at their level of consciousness, we're going to behavior now. Looking at their level of consciousness should be awake, alert, and aware. Facial expression, again, appropriate for situation. Should change when we talk about happy and sad topics. Speech is how they talk normally, and we can judge their mood and affect by asking like how you feel today and how do you usually feel. Looking at cognitive functions, we can test orientation by asking about like who they are, where they are, and what time is it. Attention span, we can ask them to concentrate on things and see if they can complete it without wandering. Looking at recent memory, you can ask them to do like a 24-hour diary call or ask the time the person arrived at the agency. And we can test their remote interview by asking things about the past, like their first job or birthday and stuff like that. And if they want to learn new things, they do the 4 unrelated words test. Some additional tests for persons with aphasia. 3 things: word, comprehensive reading, and writing. We also have thought processes and perceptions. Looking at thought processes, we can just ask, does this person make sense? Can I follow what they're saying? You can also look at their thought content, like, is this making sense? Is it logical? And perceptions, Basically, like what your perception should be, like how do you treat people. You kind of want to be in line to what yours are. And we can screen for anxiety disorders. We have this thing called the General Anxiety Disorder Scale. It's GAD-7. So basically, say like over the last 2 weeks, have you had have been bothered by the following problems? So like feeling nervous, anxious, or on the edge. Not being able to stop or control worrying. 3, worrying too much about different things. Number 4, trouble relaxing. Number 5, being so relentless as hard to sit still. Number 6, being easily annoyed or irritable. And number 7, feeling afraid as if something awful might happen. If you get a 10, that's GAD. So like 5, 10, and 15 represent like mild, moderate, and severe. But they found like 8 or higher is usually GAD. Like general anxiety disorder is GAD. Also screen for depression. That's called the Patient Health Questionnaire, PHQ-9. So we go with like, over the last 2 weeks, how often have you been bothered by any of the following problems? 1, little interest or pleasure in doing things. 2, feeling down or depressed or hopeless. Number 3, trouble falling or staying asleep or sleeping too much. Number 4, feeling tired or having little energy. Number 5, poor appetite or overeating. Number 6, feeling bad about yourself or that you are a failure or have let yourself or your family down. Number 7, trouble concentrating on things. Number 8, moving or speaking so slowly that other people could have noticed. And number 9, thinking that you might want to hurt yourself. So if you get a score of 5 to 9, that's like minimal symptoms. 10 to 14, minor depression. 15 to 19, major depression, kind of moderate severe. And 20 or higher is like really bad. Going on, we can screen for suicidal thoughts. Obviously, it's not too hard asking questions. We can also look at judgment. Express judgment when you can see a person express judgment when they compare and evaluate situations. We want to assess judgment in the context of the interview. Basically, note like what the person says about job plans and stuff like that, and it should be kind of realistic based on like their situation too. We also have this thing called the mini mental status exam. It tests cognitive mental status functions like memory, orientation to time and place, naming, reading, copying, or visual spatial orientation, writing, and the ability to follow a 3-stage command. Score is up to 30. Normal means you got 27 usually, so 24 to 30 is pretty good. 18 to 23 is a mild cognitive imperative, and 0 to 17 is like severe. And this is for dementia and delirium, by the way, too. Also, if you've had less than 12 years of formal education, an additional point is added to you. It's kind of cool. Going on to developmental competence in infants and children. Mainly the abnormalities occur with problems of omission, like the child does not achieve a milestone that they should usually hit. And we can test like problems with their mental status by using a thing called the Denver tube. Kind of cool. Looking at the aging adult, the main problem here is going to be delirium and dementia. The biggest one is delirium. Acute confusional change or loss of consciousness and perceptible disturbance may accompany like acute illness like a pneumonia, alcohol, or drug intoxication, and is usually resolved when underlying cause is treated. Delirium is treatable. Dementia, nope, no going back. Gradual, progressive process causing decreased cognitive function even though the person is fully conscious and awake. It is not reversible. Alzheimer's disease accounts for almost 2/3 of cases of dementia in older adults. This is not part of normal aging. Okay, there's also a way to screen for dementia. I think dementia. Let me read. Yeah, it's for dementia. It's called the mini cog. So you'll do like a 3-item recall. You'll name 3 items. You'll ask them to draw a clock and then draw like the hands of the clock, and you ask them to repeat it. Basically, the score is 0 to 5. 1 point is awarded for each word recalled, so that gets you 3. 2 points are awarded for a normal clock. So cool. Going on, we got a shiz ton of normal findings. Let's start off with level of consciousness. There's 5 main ones and an additional one. So like alert is number 1, lethargic is number 2, obtuned is number 3, stupor or semicoma is number 4, 5 is number coma, and additional is delirium, acute confusional state. And back to alert. It's like awake and readily aroused. They're kind of orientated and they're fully aware of external and internal stimuli and respond appropriately. conducts meaningful interpersonal reactions. Lethargic, kind of not fully alert. They drift off to sleep but not stimuli, but you can wake them up when you call them their names. Obtunded, basically sleep most of the time. Difficult to arouse, you gotta shout or shake them vigorously. And you have to keep doing something like keep them awake. With stupor or semi-coma, they're basically unconscious spontaneously. You have to really shake them to keep them awake. You have to keep responding, and they only do like moans and groans. Nothing too much. In coma, they're completely unconscious and they don't respond to any pain or external or internal stimuli. They're out. However, if they have a light coma, they might respond, but deep coma is no mode response. Looking at delirium, it's basically clouding of consciousness. You got inattentiveness, incoherent conversation, impaired recent memory, and confabulatory of recent events, stuff like that. Going on to speech disorders, got 3 here: dysphonia, dysarthria, and aphasia. Dysphonia is disorder of the voice. Dysarthria is disorder of articulation, and aphasia is disorder of language comprehension. Dysphonia is like difficulty or discomfort in talking, especially with abnormal pitch or volume caused by laryngeal disease. Causes the voice to sound hoarse or whispered, but articulation and language are intact. Kind of cool. Dysarthria, distorted speech sounds. They may be unintelligible, and but basic language is intact. Aphasia, true language disturbance. It's a defect in word choice and grammar, a defect in comprehension, defect is higher in integrative language processing. Now we're going to look at types of aphasia. Reading this, a neurally dichotomy classified aphasia as expressive, so it's difficulty producing language, or receptive, understanding, so expressive, conveying, receptive, taking in. Looking at global aphasia, it's the most common and severe. Spontaneous speech is absent or reduced to a few stereotype words or sounds. Comprehension is absent or reduced to only the person's own name and a few select words. Repetition, reading, and writing are severely impaired. Prognosis for language recovery is poor, caused by a large lesion that damages most of the combined anterior and posterior language areas. Broca's aphasia, that's the expressive. Cannot understand language but cannot express himself. The person can understand language but can't really express himself. And Wernicke's aphasia is receptive. I believe it's like he cannot understand language but can express himself. It's kind of hard to say. So like the person can hear sounds and words but can't relate them to experiences. So when you know here, global aphasia, most common and severe. Broca aphasia is the expressive aphasia. Wernicke's aphasia, receptive aphasia. Let's look at mood and affect abnormalities. Got a couple. Got like a flat affect. It's like no emotional. It's like a lack of emotional response. No expression of feelings. Voice monotonous and face immobile. A good example would be like topic. When the topic varies, the expression does not. Going on to depression, it's like sad, gloomy, dejected. Symptoms may occur with rainy weather, after a holiday, or with an illness. If the situation is temporary, symptoms may fade. And a good example would be like, I don't enjoy anything anymore. Depersonalization is like lack of ego boundaries, like loss of identity, kind of feeling strange, perplexed about identity and meaning of existence. A good example would be, I don't feel real, I don't feel like I'm not really here. Elation, joy and optimism, like overconfidence, increased motor activity, not necessarily pathologic. Good example would be like, I'm feeling very happy. It could be a sign of mania. Euphoria, excessive well-being, usually cheerful or elated, which is inappropriate considering physical and mental conditions. It implies a pathologic mood. Example would be like, I'm high, I'm feeling like I'm flying, I feel on top of the world. Next would be like euphoria, so like worried, uneasy, apprehensive from the anticipation of danger whose source is unknown. Good example, I feel nervous and high-strung. I worry all the time. I cannot seem to make up my mind. Fear, be like worried, uneasy, apprehensive, external dangers unknown and identified. Like fear of flying in airplanes. Irritability, like annoyed, easily provoked, and impatient. Person internalizes like a fear of tension, and seemingly mild stimulus sets him off. Rage is like furious, loss of control. I mean, these are pretty easy. Person has expressed violent behavior to herself or others. Ambivalence, the existence of opposing emotions toward an idea, object, or person. So like a person feels love and hate toward another at the same time. Oh, intriguing. So, interesting. Lability, it's a rapid shift of emotions. So it expresses euphoric, tearful, angry feelings in rapid succession. Wow, it's pretty neat. Inappropriate effect, clearly discordant with context of person's speech, so he laughs while talking about liver biopsy. Intriguing, but it's not their fault. Look at some anxiety disorders. Got 7 here. Look at panic disorder. So it's like intense fear, anxiety, and dread accompanied by dyspnea, choking, chest pain, increased heart rate, palpitations, nausea, and sweating. Also has fear of going crazy, dying, or impending doom. It lasts about 10 minutes and subsides. Not too bad. Agoraphobia, fear of being out in the open or in a place from which escape is difficult. It's like airport, airplane, car, bus, elevator, bridge. It's so intense that these places are avoided and person is reluctant to leave a safe place. Wow. So agoraphobia, places, dang. Specific phobia is the next one. A pattern of debilitating fear when faced with a particular object or situation. Wow, so like a dog. Fear when the dogs. It's irrational, yet studiously avoids the feared object. So it becomes restricted in social or occupational activities. Looking at social anxiety disorder, like social phobia, it's like fear of being in social situations. Thinks they're being judged and tries to avoid those situations at all costs. General anxiety disorder, they worry a lot. They're restless, they muscle tension, diarrhea, palpitations, tachypnea, hypervigilance, fatigue, or sleep disturbance. Most time to preparing for anticipated catastrophe, has problems making decisions, and practices avoidance. Looking at OCD, obsessive compulsive disorder, basically recurrent obsessions and compulsions done to decrease anxiety and prevent a catastrophe. So like fear of germs, stuff like that. So, like, intrusive thoughts and actions are time-consuming and interfere with activities of daily living. ADLs, bro. It's crazy. Looking at post-traumatic stress disorder, PTSD, basically follows, like, traumatic events, basically. Traumatic events stimulate these. Now, this one we're gonna spend Jesus, so many. Golly. You're all lucky. We're going to spend some time on this one. Delirium, dementia, and depression. Delirium, it's a acute confusional state. Can be preventable in hospitalized patients, so you're confused. It could be preventable. They are disoriented. They have disordered thinking and perceptions, defective memory, agitation, and inattention. Dementia, it's a chronic, progressive loss of cognitive and intellectual functions. Although perception and consciousness are still intact, they're disoriented, they have impaired judgment, memory loss too, and depression. It's the long-term depressed mood greater than 2 weeks with lack of pleasure. They have disturbed sleep and appetite and feelings of hopelessness, guilt, worthlessness, sadness, loneliness, and despair, like suicide ideation. So with delirium, it's usually sudden. It's over hours or days. With dementia, this happens slowly, like over months. In depression, it may be gradual, like crisis or stress. And delirium can be caused by like hypoglycemia, fear, dehydration, hypotension, infections, stuff like that. Dementia can be caused by like Alzheimer's disease, vascular disease, etc. And depression, just like losses in health, mental conditions, stuff like that. Delirium kind of there's impaired memory, judgment, calculations, attention span. These can fluctuate through the day. Dementia, also impaired memory, impaired judgment, impaired calculations, impaired attention span, abstract thinking, agnosia. Depression, can't really concentrate. They forget a lot and they don't really pay attention. With delirium, their level of consciousness is altered. However, with dementia and depression, they are not altered. Delirium, their activity level can be increased or reduced. Usually restlessness behaviors worsen in the evening. And dementia, their activity level is not really reduced and behaviors may worsen in the evening too. And that was dementia. And depression, usually decreased. Lethargy, fatigue, lack of motivation, may sleep poorly and awaken in early morning. With delirium, they have like rapid mood swings, can be fearful, anxious, suspicious, aggressive, have hallucination and delusion. With dementia, they might be flat and agitated. And depression could be really sad, paranoid, and have anxiety. With dementia, their speech is rapid, inappropriate, incoherent, and they ramble. With delirium. With dementia, it's incoherent and slow, and depression is kind of low, slow, flat, and low. This makes sense. Delirium is reversible. Dementia not reversible. Depression reversible. That's when you know. Dementia is not reversible. Delirium is. Well, depression. Let's look at some thought process abnormalities. There's a lot. Talk about blocking. So it's like sudden interruption of train of thought. So like, oh, I forgot what I was going to say. Confabulation. Making up events to fill in memory gaps. So like gives detailed description of his long walk around the hospital, although you know he was in the room all afternoon. Neologism. It's like coining a new word, inventing a word that has no real meaning. So like I have to turn on my thinkulator. Oh my lord. Circumlocation. Like roundabout expression, substituting a phrase when unable to think of name object. So like says the thing you open the door with instead of the key. What? Intriguing. It's pretty neat. Circumstantiality. It's like talks with excessive and unnecessary detail. So I'm guessing he goes in like really detail. It's like, when was my surgery? Well, I was 28. I was living with my aunt. She's the one with psoriasis. She had it bad that year because of the heat. Oh, Jesus. He knows a lot. That memory, though. That remote memory. That loosening association is shifts from like one topic to an unrelated topic. Person seems unaware that topics are unconnected. So it goes from a related topic to unrelated and stuff like that. The boss is angry with me, and it wasn't even my fault. I saw that movie too. Lassie felt really bad about it, but what? Interesting. Then like flight of ideas, abrupt change, rapid skipping from this is kind of confusing. Rapid skipping from talking. Take this pill is blue. I feel blue. She wore blue, violet. Okay, those might be hard to distinguish. Word salad. It's a mixture of words like beauty, red, base, 5, pigeon, the street, corner, sort. What? Perseveration. Repeating a modal or verbal response. I'm going to lock the door. I walk every day. I'm going to lock the door. You usually say that I'm going to lock the door. Oh. Echolalia. Imitation, repeating other words. Nurse, I want you to take your pill. Take your pill. Okay. Clanging, word choice based on sound, not meaning. My feet are cold, bold, told, the bell told for me. Oh, what a rhymer. Some more thought. Now we're going to thought content abnormality. Phobia. Fear of an object or situation like cats, dogs, heights, or enclosed spaces. Hypochondriasis. Worrying about health. Worried about having cancer even though any symptom or physical sign means cancer basically for them. Obsession, basically just unwanted persistent thoughts or impulses basically. So like violence, contamination, stuff like that. Compulsion, unwanted, repetitive, purposeful act, driven to do it. Basically hand washing, counting, checking and rechecking, touching, stuff like that. And delusions, firm, fixed, false beliefs. Irrational person clings to delusion despite objective evidence to contrary. So like grandiose person believes that he or she is God. Persecution, now they get perception abnormalities. We're almost done. We got hallucination. Sensory perception for which there are no external stimuli may strike any sense. Visual, auditory, tactile, gustatory. So like visual, seeing an image of a ghost who is not there. Auditory, hearing voices, music. Holy cow, I can relate. Illusion, misperception of an actual existing stimulus by any sense. Folds of bed sheets appear to be animated. What? Intriguing. Going on to eating problems. Anorexia nervosa. It's intense fear of weight gain. Distorted body image. Restrict calories with significant low body mass. There are subtypes like restricting and then binge eating and then throwing up basically. Bulimia nervosa. Recurrent episodes of uncontrollable binging. Inappropriate compensatory behaviors like vomiting, laxatives, diuretics, or exercise. Self-image largely influenced by body image. And then binge eating is fucking me. You got periods of uncontrollable binging without compensatory behaviors. They cause like guilt, depression, embarrassment, and disgust. It's me, bruh. It's me. And some childhood mental disorder, ADHD. Common behavioral disorder with inappropriate attention. They have short attention span, can't complete tasks or follow directions, easily distracted. Impulsiveness and hyperactivity like restlessness, fidgeting, excessive talking. Present in two settings like home and school. You also have autism spectrum disorder. Autism spectrum disorder. It's a complex neurologic and biological developmental disorder characterized by problems in social interactions and verbal and nonverbal dysfunction. Can be severe or mild. Have problems maintaining friends, stuff like that. Then you have oppositional defiant disorder. This disruptive set of behaviors characterized by negative, aggressive, angry, and irritable mood. Basically, lose temper. They argue with adults. They don't obey rules. Interesting. So they're all about bad things. Eating disorders. We went over those. So yeah, that's that. The book-wise, kind of 90%. We're gonna go over some key points in a little second. Let's go over to the workbook now. Some words I want you to know. Are there a lot of words? No, there's not too many. Abstract reasoning. Pondering a deeper meaning beyond the concrete and literal. Attention, it's like concentration, ability to focus on one specific thing. Bereavement. State of loss, sorrow, and or grief due to the death of a loved one, decline in personal or loved one's health, or end of an important relationship. Conscientiousness, being aware of one's own existence, feelings, and thoughts, and being aware of the environment. Delirium, an acute confusion or change or loss of consciousness and perceptual disturbance that may accompany acute illness, usually resolves when the underlying cause is treated. Dementia, it's gradual, progressive process causing decreased cognitive function even though the person is fully conscious and awake. It's not reversible. Executive function, highest level cognitive skills including organizational and regulatory ability. Language, using the voice to communicate one's thoughts and feelings. Memory, ability to lay down and store experiences and perceptions for later recall. Mood, prolonged display of person's feelings. Orientation, awareness of the objective world in relation to self. Perceptions, awareness of objects through any of the five senses. Thought content, what the person thinks. Thought process, the way a person thinks. Visual spatial, ability to process visual information and perceive relationships between objects in space. Cool. Now let's look at this. Questions. So, study guide. What's a mental disorder? Basically, it's a significant behavioral or psychological pattern that is associated with distress or disability and has significant risk for pain, disability, death, loss, or freedom. We know organic brain is psychological mental, so it's like organic brain is due to brain disease of known specific origin cause, and then psychiatric mental is like we're not sure. 4 situations in which it would be necessary to perform a complete mental status examination. Family members are concerned about person's behavioral changes. brain lesions, aphasia, symptoms of psychiatric mental illness. Also look at 4 factors that could affect a person's response to the mental status examination but have nothing to do with mental disorders. Any known illnesses or health problems, current meds whose side effects may cause confusion or depression, the person's unusual education and behavioral level, responses to person's history questions indicating current stress, social interaction patterns, sleep habits, and drug and alcohol abuse. What are some convenient ways to assess a person's recent memory within the context of initial health history? Assess recent memory within the context of an interview, like a 24-hour diary call, or ask the time the person arrived at the agency. Ask questions you can corroborate with the family member. Which mental function is the 4 unrelated words test intended to test? Ability to lay down new memories. What are 4 questions you could ask a patient that would screen for suicide ideation? Have you ever had thoughts of hurting yourself? Do you feel like hurting yourself now? Do you have a plan to hurt yourself? What would happen if you were dead? How would other people react if you were dead? So we know that now. So lastly, some questions. Going on number 1. Although a full mental status examination may not be required, you may be aware of the 4 main headings of the assessment while performing the interview and physical examination. What are they? Appearance, behavior, cognition, and thought process. I'm going to give you an example of a thing that most accurately describes the appearance of a patient. It's like tense posture and restless activity. Clothing clean but not appropriate for season. So let's talk about this. You are assessing short-term cognitive function. Which assessment shows the ability to lay down new memories? Talked about it. It's the 4 unrelated words test. Next, you are preparing a discharge plan for a patient with aphasia. What assessment should you include in the plan? Ask the patient to demonstrate word comprehension by naming articles in the room or on the body as you paint them. During an interview with a patient diagnosed with a seizure disorder, the patient states, "I plan to be an airline pilot." If the patient continues to have this as a career goal after teaching regarding seizure disorders has been provided, you might question the patient's what? Judgment. On the patient's second day in an acute care hospital, patient complains about bugs on the bed, or the bed is clean. This would be an example of altered what? Perception. One way to assess cognitive function and to screen dementia is with what? The mini-cog. We know that. A major characteristic of dementia is what? Impairment of short and long-term memory. I didn't know that. What statement is an example of patient with dysarthria? Word choice and grammar are appropriate, but the sound are distorted, so speech is unintelligible. You are leading a discussion of the planned activities for the day at an adult living center and state, "We will be having snacks at 9:30 and lunch will be at noon." One of the participants responds in a very monotone manner, "Snacks at 9:30, lunch at noon, snacks at 9:30, lunch at noon." This is a sign of echolalia. You are performing a mental status examination. What's a good appropriate examining patient's response? What is a priority assessment for aging adults? Irrational thinking patterns. Cool. You are assessing a 75-year-old man with expected firing. It may take him a little longer to respond, but his general knowledge and ability should not have declined. When assessing mental status in children, what statement is true? All aspects of mental status in children are interrelated. Alright, one more thing to go over. This is very long. Very long. These key points. So, mental status is a person's emotional, feeling, and cognitive knowing function. Its functioning is assessed by evaluating the individual's consciousness, language, mood and affect, orientation, attention, memory, abstract reasoning, thought process, thought content, and perception. Mental disorders are apparent when a person's response is much greater than expected reaction to a traumatic life event, including organic disorders and psychiatric mental disorders. A full mental status examination is a systematic check of emotional and cognitive functioning. Its purpose is to determine mental health strengths and coping skills and to screen for dysfunction. For most patients, mental status is assessed throughout the content of the health history interview. A separate full mental status examination is required in the following situations. Blah, blah, blah. Every mental status examination should consider the patient's physical illness, current medications, educational and behavioral level, and responses to personal history questions. The four main components of the mental status assessments are what? Appearance, behavior, cognition, and thought processing. A, B, C, T. To assess appearance, observe the patient's posture, body movements, dress, grooming, hygiene, and pupils. To assess behavior, evaluate level of consciousness, facial expression, speech and articulation, and mood and affect. Back up. To assess cognitive function, check orientation, attention span, recent memory, remote memory, and new learning. For patients with aphasia, test word comprehension, reading, and writing. To assess thought processes, ask questions to evaluate thought processes, thought content, and perception. Also screen for anxiety disorders, depression, and suicidal thoughts. An additional component of the mental status examination is to assess the patient's judgment, person's rationales for actions related to health care. Should be realistic. Looking at the mini mental state examination is a simplified score assessment of cognitive functions, not mood or thought process cognitive functions. It includes a brief assessment of memory, orientation to time and place, naming, reading, copying or visual spatial orientation, writing, and the ability to follow a 3-stage command. It requires paper and pencil. Consciousness, language, attention span, and abstract thinking all developed over time. When examining an infant or children, consider these factors from a developmental perspective. For pediatric patients, the mental status assessment focuses on child's behavioral, cognitive, and psychosocial development and coping with his or her environment. The Denver 2 test allows direct interaction with the young child to assess mental status. The ABCT guidelines used for adults may be used for children and adolescents, taking into consideration developmental milestones. Although aging leaves mental status parameters mostly intact, a slower response time may affect new learning in the older adults. Age-related physical changes such as vision or hearing deficits may affect an older adult's mental status. Before assessing an older adult's mental status, check sensory status and correct deficits, if possible. For testing consciousness in aging people, the GCS Glasgow Coma Scale is a useful quantitative tool. Minicog is a reliable, quick instrument to screen for cognitive impairment in otherwise healthy older adults. So I hope you enjoyed this. It's pretty long. Can't wait to watch it over and over.